My name is Roger Lewis, and for a period of over a year, I served as the head of the Los Angeles County Department of Health Services COVID-19 Predictive Modeling team. It was my pleasure to lead an amazing multidisciplinary team over a period of approximately 15 months while we took on the challenge of predicting the course of the COVID-19 epidemic threatening the welfare of over 10 million people living in Los Angeles County. In March 2020, the emerging COVID-19 pandemic presented the County of Los Angeles and the Department of Health Services specifically with a monumental challenge. New York City's experience during the early pandemic had demonstrated that major metropolitan areas and their healthcare systems were vulnerable to being overwhelmed with devastating consequences for their patients and their communities. Similarly, the demand generated by the pandemic for acute hospital care, intensive care unit care, mechanical ventilators, and morgue services had the potential to exceed the available resources of Los Angeles County. At the beginning of the epidemic, back in the spring of 2020, there was a nearly paralyzing lack of reliable, quantitative information about the number of cases and rate of spread, and moreover, the information that was available was often unreliable and sometimes sensationalistic. There were many different predictive models. There were different statistical approaches to predicting what lay ahead, though none of them seemed particularly applicable to LA County, nor based on accurate data regarding what we were seeing in the hospitals, both within DHS hospitals and in hospitals across LA County. The lack of good predictive models made the job of responding to the increasing number of cases and preparing for what lay ahead even more difficult. So in March 2020, we put together a team to create a statistical model to predict the impact of COVID-19 on the healthcare system across Los Angeles County, paying particular attention to the likelihood that we would run out of hospital beds, ICU beds, and mechanical ventilators. To develop our statistical approach to predicting the epidemic, we assembled a team that included not only personnel from Los Angeles County, including the Department of Health Services, Public Health, and the Office of the CIO, but also epidemiological, biostatistical, and mathematical experts from UCLA, and experts in Bayesian statistics and computer simulation from Berry Consultants, a statistical consulting firm in Austin, Texas. And the team produced publicly posted weekly COVID-19 activity and resource utilization forecasts from April of 2020 through May of 2021. These forecasts allowed DHS to provide the public and news media with timely and accurate information about projected healthcare resource availability. It served as an early warning system for surges in disease activity and made possible the implementation of mitigation strategies to reduce death and suffering caused by the pandemic in Los Angeles County. Any statistical prediction model is completely dependent on the quality and timeliness of the data supporting it. The publicly reported case counts couldn't be used for accurate predictions because there was such a limited availability of tests, and even to this day, most people with COVID are never tested and aren't represented in official case counts. Since our goal was to understand and predict the impact on hospital services, we needed accurate data on what was going on in the hospitals. Luckily for us, the Los Angeles County EMS agency, under the leadership of Kathy Chittister, Dr. Gaucher Hill, and Ricky Tadeo, rose to the occasion. I am convinced to this day that we had the most accurate and timely data on what was going on in the hospitals compared to any other team in the country that was trying to understand the dynamics of the epidemic.
We have an extended multidisciplinary advisory team. For more than a year, we held weekly meetings with colleagues from UCLA, County Department of Public Health, and the City of Long Beach to exchange knowledge and leverage each other's domain expertise. This collaborative approach is critical to the success of our modeling effort.
Hello, my name is Richard Tadeo. I'm the Assistant Director for the Los Angeles County Emergency Medical Services Agency. I'm here to give you a brief overview of the data validation process we implemented for the COVID demand modeling project. On a daily basis around 9 in the morning, the EMS agency sent 2 polls to 71 911 receiving hospitals via a communication system called the ReadyNet. The first poll involved 20 questions regarding the number of confirmed and suspected COVID patients, the number of admitted patients on the regular med-surg, telemetry, step-down, and ICU units. We also collected data on the number of patients receiving mechanical ventilation, the number of patients who tested COVID, and those that resulted with a positive test. Simultaneously, we sent a separate poll requesting the hospitals for the number of available staff beds, both for the med-surg units, the step-down, telemetry, and intensive care units. The hospitals were given until 12 noon each day to submit their data. The EMS agency then collated the results for both polls, and in the afternoon, around 3 p.m., we forwarded the data to the statistician.
We then ran an algorithm that we had devised to check for outliers. In other words, possible data entry errors. The EMS agency staff then called hospitals to verify or correct the data. After that, cleaned aggregated data was passed on to the modeling team. This was a labor-intensive daily process, which did not stop for weekends or holidays, but resulted in a precise, near real-time understanding of COVID-19 activities in Los Angeles, which fed our epidemic model.
In April of 2020, when the team began to think about how to model and predict the need for healthcare resources in the COVID-19 pandemic in Los Angeles, we realized that we would need high-quality data about the number of new infections that were occurring each day. After all, a model is only as good as the data it's based upon. Measuring new infections is less straightforward than it sounds. Because tests were very limited at the beginning of the pandemic, we knew that positive tests, that is, cases counted by the Department of Public Health, were not capturing all of the infections. This remains true to some extent even as testing becomes more available. We can think of the epidemic a little bit like an iceberg floating in the water. If the iceberg is all of the infections, then the cases are the part that we can see above the water, and hospitalizations are just the very tip of this iceberg. The challenge we were faced with was how to measure what we couldn't see, all the area below the water. We devised a system to use hospitalizations to estimate total daily new infections, assuming that the new hospitalizations for COVID-19 represented a fixed fraction of all new infections in Los Angeles that had occurred a few days earlier. This required coordinating with the Los Angeles Emergency Services Agency to poll all 70 911 receiving centers in the county daily regarding their new COVID-19 admissions.
In constructing our predictions, we faced multiple challenges. First, pandemics are driven by the number of susceptible and infectious individuals, and we wanted a model that allowed us to directly estimate the number of people in each of these categories. Second, human behavior matters. As the pandemic waves grew and shrank, Los Angeles enacted public health measures, and individual people became more or less careful depending on their individual circumstances. We required a model that reflected this reality. Third, and perhaps most important, we wanted to acknowledge our uncertainty. We wanted to be precise, but first and foremost, we wanted to be right. Sometimes that required giving estimates with large ranges. We modeled the pandemic using an SEIR model. At the beginning of 2020, everyone in Los Angeles was susceptible to COVID-19. Eventually, many became exposed and in time began infecting others. Eventually, these infected individuals recovered, or sadly died, and became at least temporarily immune. The SEIR model directly describes these states, with the letters in SEIR standing for susceptible, exposed, infectious, and then recovered. Each week, this model provided direct estimates of the number of people infectious in LA. These results, such as 1 in 95 Los Angeles County residents are currently infectious, were quoted nationwide on television and news providers such as CNN and the New York Times. A key part of any disease model is the effective reproductive number R. This measures how quickly the pandemic is growing or shrinking at any given time. Values of R above 1 result in exponential growth of cases, while values of R below 1 result in decreasing cases. R is changing constantly. People are infected and then recover, leaving fewer people susceptible to the disease. Variants may appear, which may be more transmissible. Importantly, people may also change their behavior. Our model included the ability to estimate these changes in effective R and predict them forward. The biggest change occurred in March 2020 with the initial LA lockdowns, which cut transmission in half over the course of 2 weeks. As the pandemic continued, we could estimate the current level of actual distancing in LA and use that to guide our predictions forward. We consistently saw behavior changes in reaction to the number of cases. Times of high transmission made people more cautious. Times of limited cases made them less so, creating a feedback loop which kept R in a narrow range. Throughout the pandemic, we wanted to convey our uncertainty in our estimates. No one can perfectly predict the future. At most times, we could accurately predict the next 4 to 6 weeks ahead, but there were times where we knew we had to wait for more data and not guess. The winter surge is a good example. After the summer 2020 surge, COVID stayed at a low level throughout much of the fall. We couldn't get rid of it, but it wasn't rising. Then, in November 2020, we got our first alarming data. These are the predictions on November 18th, 2020. In the few days prior, there had been a sudden rise in hospital admissions. We knew this trend was going to continue and would likely become a major wave, but could not be certain of its magnitude. Maybe something new had arrived. In fact, a new transmissible variant had arrived. Maybe it was holiday gatherings. We could not be certain. Our predictions made it clear that hospitals should be preparing for a major surge, but of unknown magnitude. Here, our most likely band of predictions ranged all the way from 1,800 to well over 5,000 beds needed. It said prepare as fast as you can, but not clearly for what.
The county also released a new and grim public service announcement ahead of the holiday weekend, urging people to follow recommended guidelines and avoid becoming hospitalized with COVID-19.
The hospitalization model that I just walked through suggests that about 1 in every 145 Los Angeles County residents are currently infectious.
As the winter unfolded, we were continually able to provide more and more precise estimates. On December 23, 2020, contrary to many pundits who predicted a post-Christmas acceleration, we could see the peak a month in advance. While admissions were still rising exponentially, the model could see the growth was slowing and predict that the peak would be mid to late January, with the peak likely under 9,000 beds occupied. This prediction was quickly realized. These are the predictions on February 10th, 2021. The actual peak in hospital bed usage occurred in mid-January at 7,500 hospital beds in use. By February, cases and hospital use were all declining rapidly, a trend which continued until the arrival of the Delta variant.
From early April 2020 through May of 2021, we produced over 50 separate updates to the prediction model, with each providing quantitative predictions for 4 weeks into the future. The 4-week timeframe was short enough that the predictions could be more precise and therefore represent actionable information, and long enough to aid in the extensive preparedness and response activities occurring across the healthcare system in Los Angeles County. The projections were posted on the DHS website, with virtually all available in both English and Spanish. Through the end of 2020, the posted projections were accessed over 20,000 times, and 10 additional sites linked to the projections. And most importantly, the model was predictive and was constantly proved correct. The model served as an early warning system for upticks in disease activity, correctly projecting the summer and winter surges, and equally importantly, model projections of downward trends in COVID-19 activity informed decision-making regarding the county healthcare system's capacity to reopen resources for care unrelated to COVID-19 disease. Overall, we believe that the mitigation strategies made possible by accurate model forecasting reduced death and suffering related to the pandemic in Los Angeles County. The hospital demand model was a cornerstone of the county's public information strategy as implemented in the weekly press conferences. The public-facing strategy included sharing the model and its predictions with the public to increase awareness and to engender an accurate and data-driven understanding of what was happening and what could happen as a result in hospitals across Los Angeles County, and to encourage the public to adhere to public health safety messages. The model was a critical communication tool in explaining that what was happening in our hospitals at any time reflected what happened in our communities just a few weeks earlier, and that what people did on a daily basis in their communities had a real impact on our hospitals. By framing the model's projections and potential future scenarios as dependent on community behavior, the model was designed to not simply inform hospital management strategies, but also to empower the public to take control of their own behavior as the key lever that made the difference. The model was highlighted in a variety of communications efforts. For most of the pandemic, Dr. Galley spoke at the weekly or bi-weekly county media briefings, and during these briefings, Dr. Galley consistently showcased the model to explain the current situation, current trends, and the model predictions. In addition, at a few key moments at the introduction of the model and at key time points during surges, we held press-only media briefings to specifically educate the press on the model, how it worked, and how to interpret it. Our belief was that if we wanted the model to be effective in mainstream media coverage, we had to support reporters and producers in understanding its value and how it worked.
The reopening was so important for saving a lot of small businesses, for helping people get back to work so that they could put food on the table. And I think that was the right choice. What matters, though, is how it's done and how seriously everyone takes all of those directives.
On both the local and national level, we pitched a variety of key expert and representative spokespeople to a diversity of reporters, producers, and television news anchors through targeted pitching.
A negative test is not a pass to play. A negative test is actually simply a snapshot at that time.
We also developed a speakers bureau consisting of experts speaking multiple languages and representing multiple ethnicities.
Desperately trying to figure out where to move patients to free up beds because there's people now in the ED who need ICU care.
At key inflection points throughout the pandemic, this was one of the most powerful ways to get the message across to the public, and the model often informed and drove key messaging and strategy. As a result of our concerted efforts to communicate what was happening in the hospitals and in our communities through the lens of the model and its insights garnered extensive local and national media coverage. Locally, that included all the affiliates, ABC, CBS, Fox, NBC, as well as Telemundo, Univision, KTLA, and Spectrum.
We are seeing a very large number of patients in the emergency department. And I am concerned that we're not at the place where we're seeing the highest numbers we will see even with the Thanksgiving gatherings.
Nationally, the model and its insights were consistently discussed through interview segments on MSNBC, CNN, Good Morning America, and The Today Show.
No physician or nurse in the United States of America ever expected to work under a crisis standard of care. But what it is that we run out of critical resources.
A recent search for media activity highlighting or based on the predictive model yielded 387 online news articles, over 100 blog references, 40 separate newspaper articles, and numerous examples of television and radio interviews. Newspapers that included model results and graphics created by the modeling team included the New York Times, the Washington Post, and the Los Angeles Times on multiple occasions.